Hey folks, Ross here from OpenAirway, currently in the UCT Anesthesia Skills Lab, and we're talking supraglottic airways. In this quick video I want to talk about the indications, the selection of a supraglottic airway, the precautions of when it might not be a good time to use, how to pick the right size, place it, perhaps one or two tips about just troubleshooting a little bit and using it for ventilation. So we recognize that particularly in anesthesia, supraglottic airways are first designed for where we want to perform general anesthesia and try and avoid intubation, or perhaps we want to keep the patient breathing spontaneously. We don't want to do something as invasive as intubating, and for that we can place a supraglottic, let them breathe, or if it seals well, actually ventilate the patient positive pressure. And we still have specifically designed supraglottics for this in the operating theatre, and some for specific indications, such as these are flexible LMAs. They're designed to be placed and then you can take the tube down and out of the way of the surgeons. They can operate on the eyes or do ENT procedures. But really, you can imagine trying to use one of these floppy devices in an emergency setting would be probably quite a bad idea. So let's eliminate those from the equation. We're recognizing more and more now that in an emergency setting, so either for obtaining an airway as a primary intervention, let's say during a resuscitation with ongoing CPR, or where the skills for intubation don't exist, where the access to the patient is limited, then placing a supraglottic as your primary airway intervention may be a good idea. And also we recognize that these devices are excellent for rescuing a failed intubation situation. We know that where intubation has failed in an unanticipated difficult airway, we can 9 times or more out of 10 rescue that situation by placing a supraglottic. In the emergency setting, we've got to be thinking about, down the line, are we going to want to ventilate this patient? So we might want a device that has got improved sealing pressures. Are we going to try and protect this patient against aspiration? So we're probably going to want a second or third generation device which is going to offer some kind of gastric drainage and aspiration protection. We might want to place a nasogastric tube, for instance, and decompress the stomach. And then we've got to be thinking as well, am I going to need to move on to using the supraglottic as a conduit to intubation? So those are some of the thoughts that are going around in my head. You've got to also recognize that there are situations where using a supraglottic is going to be contraindicated, or it's going to be very difficult. And I like the acronym RODS. It's quick and simple, just shoving a rod in there, shoving a supraglottic in. When am I going to struggle? So it's patients with restricted mouth opening, where the mouth opening is not adequate to get the device in, and you recognize you need a couple of centimeters to get one of these devices in. Patients where there is an obstruction in the airway which is going to prevent placement of the device, recognizing that most of these devices need fairly normal anatomy in order to sit and seal well. So if there's an obstruction or a disruption of the anatomy or distortion of the anatomy, that's not going to seat well, it's not going to seal well, and it's not going to be able to ventilate the patient. And so that's the R for restricted mouth opening, O for obstruction, D for distortion, and the S is the patient with stiff lungs. So I'm thinking of the asthmatic, the COAD, the patient with airway burns, or the morbidly obese patient, where I'm going to need high ventilatory pressures in order to ventilate them, and these devices don't provide as good a sealing pressure as, for instance, an endotracheal tube where you can seal with 50, 60, 70 centimeters of water. These devices typically will start to leak at 20, 30, maybe 40 centimeters of water if you're lucky. So we must be aware of trying to ventilate patients where I anticipate high pressures, because these devices probably won't seal well enough. So restricted mouth opening, obstructions, deformities, and stiff lungs, situations where it might not be a great device. So, decided that I'm probably going to want to select a device that is going to offer some gastric drainage, so I'm probably going to avoid my first generation style devices. I'm going to go for something that's got provision for placement of nasogastric tube, perhaps an enhanced sealing pressure, and I'm going to think about whether, if this is a patient I want to intubate down the line, using a device that's going to allow that. How do I choose the right size? So you can see I've got a large spread here. These devices are typically sized according to the patient's lean body mass or ideal body weight, and sometimes according to the patient's height. And you'll know that ideal body weight and height are often reasonably equitable. So you'll see on most devices, somewhere on the packaging on the device themselves, it will have printed what size range is appropriate for this particular device for this particular patient. And the sizes tend to go 1, 2, 3, 4, 5, sometimes they're half sizes, and you'll find that a size 3 in one device is probably of a fairly similar range in size to a size 3 in another device. Typical medium-sized adult, you're looking at about a size 4 across most of the devices. So an NMA, a size 4 is a 50 to 70, and an iGel, a size 4 is a 60 to 90 kilograms. Very, very similar kind of sizing. So select the sizes appropriate for your patient's ideal body mass. Don't look at the lady who's 1.5 meters tall but weighs 130 kilograms and think that you're going to need a size 6 for her, because I promise you're not going to get it in. Okay, so we've selected a device, we've selected a size, we know there's no obvious contraindication. How are we going to insert it? So the most classic insertion technique, if we're looking at using an LMA for instance, is that you're going to deflate your cuff. You're going to apply a good quantity of a water-based lubricant. Obviously in plastic patients here I'm using a mannequin lubricant to the back of the device with it in a sterile packaging. Make sure that the lubricant is nicely spread in the back of the device. Avoid getting it into the bowl of the device. And then the very classic technique is with the patient obviously fully obtunded, so either entirely unconscious and unresponsive or using some sedation and perhaps paralysis. You're going to use your finger as an inserter, lift the jaw, insert the device and advance it until it seats itself. And I often just sort of with a bobbing motion you can feel that it's kind of slipped into its anatomical seating, and then inflate the cuff. Sometimes you can see that the device will rise ever so slightly as it moves into the correct position, and then you're able to connect your ventilation source and you're able to ventilate your patient. If you don't get good ventilation or good sealing, what you can then do is deflate your cuff a bit, advance the device a bit further. Sometimes doing a jaw thrust and advancing the device will help you, or you do a jaw thrust and let someone else move it, and then inflating the cuff, drawing it back slightly until it seats well while providing ventilation to find that optimal spot where it ventilates best, and then secure the device. Now, some of the newer devices, many of the second generation devices have got more rigidity to them. So for instance, here's an iGel. Again, it's got gastric drainage, so it's a second generation device. You can put some lubricant onto the little frame it comes in, lubricate it nicely, and because this device is a little bit more rigid, I can again insert it, voila, and it goes in. iGel, of course, not having an inflatable cuff, it's gel, molds to the shape of the patient's airway, and now I can ventilate, and off I go. Another slightly more rigid second generation device is this LMA Supreme. You can see that it's got this nice curvature, this pre-curved shape to it. So what I recommend to people when you're working with inserting these devices, especially when they've got a pre-curved shape, use the shape of the airway to your advantage. So imagine that you're touching the stem of the device, or physically touch the stem of the device against the patient's chest, and then with the tip going up against the hard palate, follow the curvature of the airway all the way around. So hard palate, soft palate, posterior pharynx, and down into, with the tip sitting in the most cranial portion of the esophagus. Where's my syringe? There we go. And off you go. So you'll see these devices with inflatable cuffs. Obviously, time allows, you're going to be checking your cuff beforehand, and many of them will have the volume of air printed on them. The best way, of course, to make sure that your cuff is adequately inflated is to use a cuff pressure manometer. Some devices do come with an adjunct to insert the device, so either some kind of internal rod stiffener, or for instance this ProSeal has got an introducer that comes with it, and again you'll see that it gives the device that pre-curved shape. This is a size 5 ProSeal, which might be a little bit too big for the American man here, but let's have a look. So again, imagining I'm touching the stem against the patient's chest, I'm lifting the jaw slightly, one goofy foot with my hands here, and then advancing this device until it's seated fully, out with my introducer, following the curvature, inflate the cuff, and off we go. So that's insertion of some of these devices. Now, one way to check that your device is sitting in the perfect position is that if it's got a drainage tube once it's inserted, you can pass a nasogastric, well lubricated nasogastric tube down here, and if it goes down freely and you can aspirate gastric contents, then you know the device is sitting ideally. In the next video I'm going to show you the Brimacum maneuver, which is to use this gastric drainage tube and a bougie to allow you to place the device quickly and effectively in tricky patients. So that's some tips on the indications, the contraindications in certain patients, the sizing and the placement of supraglottic airways.